Hello everyone, this is Dr. Chandani Seth. I'm an endocrinologist practicing in Mumbai, Mira Road. And today we are going to discuss a case study of diabetes. This is a 58-year-old patient with diabetes, obesity, hypertension, dyslipidemia, and OSA. So this type 2 diabetes patient has diabetes since last 4 years and is on metformin 1 gram twice a day with a HbA1c of 8.3%. Other than that, there is also obesity and his BMI is 32 kg per meter square. He has hypertension and is on treatment with lisinopril 40 mg and metoprolol ER 100 mg once a day. So at present, his pulse is 60 beats per minute and blood pressure is controlled at 130 by 80 millimeters of mercury. He also has dyslipidemia and OSA and is on treatment with atorvastatin 40 mg. With that, we have achieved the LDL goal of 69 milligrams per deciliter, but HDL is low at 35 and triglycerides are slightly high at 250 milligrams per deciliter. And he's also on aspirin low dose for primary prevention. And his systemic investigations show that he has an eGFR of 70 and his AST and ALT are slightly elevated at 70 and 100. So this is our case today, and it's a common case coming to our clinics regularly. So now we need to treat this patient. So what are the points that we think of when we are initiating treatment in such a patient? What second line drug should we give? He's already on lifestyle modification, metformin. He has a good BP control, good LDL targets, but his HbA1c is elevated. So when such a relatively young patient who is 58 and he has diabetes just for 4 years, so a very short duration of diabetes, and he has no established cardiovascular or renal complications at present. So there are no major comorbidities that would reduce his life expectancy. And he's only on metformin. He has not reported any episodes of hypoglycemia. So there is a low risk for hypoglycemia in such a patient. So in such a patient, we must aim for a stringent goal. So we can get his sugars as close to normal as possible without increasing any risk of hypoglycemia. If we look at the guidelines currently, the ADA recommends less than 7% HbA1c for most non-pregnant adults. And when we read the ADA guidelines, apart from HbA1c, there are many things that we can consider when choosing a second-line therapy after lifestyle modification and metformin. So some of these factors are risk of hypoglycemia. So to minimize the risk of hypoglycemia, we look at agents like SGLT2 inhibitors, DPP4, and GLP-1 analogs. Another caveat is to minimize weight gain or cause weight loss. Again, in this category, we have SGLT2, GLP-1, which can cause weight loss, or DPP4 inhibitors, which are weight neutral. Apart from that, we have to consider the presence of heart failure, ASCVD, CKD. In these also, a preference has been given to GLP-1 and SGLT2, and presence of heart failure also gives us a leverage with SGLT2 inhibitors. And apart from this, cost is also something that we must consider before giving therapy to the patient. Now, apart from all these medications that the patient is taking, which are 4 to 5 already, so when we explain the patient that his HbA1c is above the target and he will need certain medications, so he expresses his concerns that he does forget to take his pills and he's tired of taking so many pills. And we explained to him that with an HbA1c of 8.3, no one drug will be able to achieve a target limit. And any oral drug can only get you about maximum 1% reduction. So he refuses for any injectable therapy. So one of the things that we can give him is a fixed dose combination, so that he has to take a single pill and the pill burden will reduce, the cost will reduce, and some of the side effects may be cancelled, and this will improve patients' adherence, compliance, and improve HbA1c control. Apart from the HbA1c or the glycemic control, today the concept has moved to beyond the glycemic control, which means that it is not just the sugars that we are aiming for, but it is the whole pathophysiology of diabetes, or all the defects that we have which lead to diabetes should be addressed. And the recent ADA update also tells us that prefer a combination therapy, because it will help the patient to achieve glycemic control better, in a better way, as well as it will be more durable. So our combination therapy should be favored. And in high risk individuals, like we talked about, if there is a need to reduce MACE, heart failure, CV death, CKD, then irrespective of HbA1c, even if the sugars are controlled, HbA1c is good, still we should consider SGLT2 or GLP-1 analog. So coming back to this patient who requires at least 1.3% HbA1c reduction, which we will not be able to get with any single oral drug, we can consider SGLT2 and a DPP-4 combination in this patient, which will help him to come to the goals. So SGLT2, we all know, is an oral glucose lowering agent that will block the SGLT2 inhibitors in the proximal tubule of the kidney, and this will cause glucosuria, hence reducing the blood sugars. And apart from the effect on glycemic control and hyperglycemia, it will also have many pleiotropic effects due to osmotic diuresis, natriuresis, increased tubuloglomerular feedback, and give us cardiovascular and renal benefits as well. And we have a landmark EMPA-REG trial done in high-risk patients, which shows us the superiority of empagliflozin in reducing the 3P MACE. And when we talk about DPP-4 inhibitors, these act by increasing the GLP-1 or the incretin hormones, because it is targeting the DPP-4 enzyme, which is metabolizing these hormones, which will then lead to a insulin secretion. So SGLT2 is acting in an insulin independent manner, and DPP-4 is just augmenting the insulin release. So for DPP-4, we have linagliptin, and the CV safety has been proved in Carmelina and Carolina trials for linagliptin. So in this patient, we can use EMPA and Lina combination, because there have been many studies on this combination, many real world data is available, which shows that there was a study which has shown that in patients who had a baseline HbA1c of more than 8.5%, there was an achievement of 1.8% HbA1c reduction with this drug, as compared to any monotherapy in patients who were already on metformin. So this was durable as well. This benefit was maintained at 52 weeks, and more patients who were on this combination therapy achieved a target HbA1c of less than 7% as compared to anyone who was on a monotherapy. So this combination offers a component in strategy to achieve target HbA1c without any increased risk of hypoglycemia, without any weight gain, probably weight loss, and with an overall improvement in lipid profile as well. Another theory about cancelling the side effects is that a meta-analysis has shown that when SGLT2 was used with DPP-4 in a combination, meaning simultaneously, apart from the better glucose control, there was reduction in the genital infection, which are usually common with SGLT2 inhibitor use. So there are many theories to support it. Some say that it may be just because there is a better glucose control. Some theories have also suggested that the bacteria and the fungi which are causing the infection has some DPP-4 enzyme which is being inhibited by the DPP-4 inhibitors. So the possible mechanisms still need to be investigated, but this was an observation seen in a meta-analysis. So to summarize, EMPA-LINA will provide a robust HbA1c reduction, and the it will have 2 to 4 times higher odds of the patient reaching the HbA1c goal and give a very low hypoglycemic. So that is from my side about this case. Thank you.